Good afternoon, ladies and gentlemen. Welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would now like to turn the meeting over to your moderator, Jennifer Thornhill-Verma, Senior Director at CFHI. Please go ahead.
Thanks so much, and thanks everyone for joining us. We want to start by acknowledging that we're meeting on land that has been inhabited by Indigenous people since the beginning. In particular, we're acknowledging that we're broadcasting this webinar from Ottawa. So it's the traditional and unceded territory of the Algonquin Nation, and we recognize and deeply appreciate their historic connection to this place and the opportunity to gather here today. And we also express our gratitude as we're gathering across the country. The topic today is health innovation and the evolution of patient partnership. A couple of items of housekeeping before we get started. Take a moment to introduce yourselves using the chat box. We had an opportunity to see there were some folks in Calgary and as far-reaching east in St. John's, Newfoundland and Labrador, but introduce yourselves. If you came to this webinar with any questions off the top, we're happy to hear them. We're going to be taking questions certainly at the end and potentially as we go. Tell us the organization that you're from and also ways that you're partnering with patients and families. On this webinar, as with all of our webinars, we're pleased to provide simultaneous interpretation, a fully bilingual chat box. At any time throughout the webinar, please send in your questions via chat, English or French, and we've reserved a few minutes at the end, as I said, to share questions. All right, so who's with us today? As our moderator had said, I'm Jen Thornhill-Verma, Senior Director here at the Canadian Foundation for Healthcare Improvement, and I'm especially pleased to be joined by Julie Drury. She's our new strategic lead for patient partnerships at the Canadian Foundation for Healthcare Improvement. We announced in September Julie's joining CFHI, and she brings over a decade of experience both as a family representative and patient partner with local, provincial, and national organizations, which I think, Julie, positions you really uniquely in terms of your work in this area. And some of the work that Julie's doing is with us, with CFHI, to help us grow programs and initiatives that drive and support partnerships in real system change. We also have Lindsay Yarrow, who typically joins us from Kingston, but is here in Ottawa today, so welcome. And Lindsay's the Senior Improvement Lead for our Priority Health Innovation Challenge. All right, we're going to move into some of our objectives. So what would we like to achieve on today's webinar? So it is part of our Priority Health Innovation Challenge webinar series, so you'll certainly be hearing a little bit about that. We do have current teams who are participating in that challenge online with us today. So if you are a Priority Health Innovation Challenge team, please do introduce yourselves as well. This is a great opportunity for you to share the work that you're doing, and Lindsay's going to speak to that. In brief, the challenge is really about working together to improve access to mental health and addiction services in home and community care. And so we put out a number of indicators that were identified as sore spots in health system improvement in Canada, and these teams are responding to those areas, and they are working with patients and families to get there. So we know that work in this area, as I think anywhere, I mean, who knows better the care experience than those experiencing it? How do you improve care without involving those who are part of that care? It can only be successful with true engagement and partnership. Julie's going to tell us what those kinds of terms mean. We're going to focus on principles and strategies for building patient and family partnerships and how to build environments where patient and family partnership becomes part of the organizational culture. We're also going to share with you more about the Priority Health Innovation Challenge. We'll slip that in, and how you can join in that opportunity, which remains open for recruitment. So without further ado, I'm going to pass it over to Julie.
Thanks so much, Jennifer, and it's great to be online with all of you this afternoon. Thank you so much for joining us. And so I'm going to walk you through, over the next little bit, some concepts around patient engagement, patient partnership, patient experience, patient leadership, patient-centered care. The list goes on and on. We've got lots of terminology floating around now in our healthcare policy space, and I am very much going to focus on policy and what that looks like from a pan-Canadian perspective, and what that might mean for those of you joining us on the phone from a health innovation point of view, the importance of bringing patients, families, and caregivers into the work that you do. Here at CFHI, we are very focused on patients, families, and caregivers as partners. In fact, in our 2019-2021 strategy, where we define improvement as a team sport, if you look at our definition of partnership, patients, families, and caregivers are listed first and foremost. And that is not a mistake, and that is not, sort of a level-setting hierarchy. It actually is a foundation of the work that CFHI does, and the philosophy here that we live a culture of engagement. Of course, we work very closely with health and social service providers, governments at all levels, regional, provincial, and national and federal, and we work with many other individuals in public across the private sector who are committed to healthcare improvement. Here at CFHI, we have identified 6 levers for healthcare improvement. My favorite lever, as biased as I am, is on your bottom left-hand corner, engaging patients and citizens. Again, reinforcing the CFHI culture and perspective that when you're working with us on one of our collaboratives, one of our program initiatives, or one of our healthcare innovation initiatives, that there is a high expectation that engaging patients and citizens will drive on that improvement initiative. And I was just going to say balancing that with frontline managers and providers, the focus on population needs, the creation of supportive policies and incentives, the building of organizational capacity, and the promotion for evidence-informed decision-making. So it's a team approach. It's a partnership approach. Patients, families, and caregivers are persons with lived experience that have expertise and knowledge that is invaluable to how we create our programs and how we support those of us working with us on innovation challenges. Integral members of the team is our philosophy here at CFHI. So I hope I've laid for you the groundwork of our culture here, how our organization functions, and I'm hoping that over the course of the next 15, 20 minutes or so, I can help to share with all of you what this looks like perhaps from your perspective and how your culture is working towards a better patient engagement capable environment. So I'm going to outline for you some of the principles and some of the definitions for patient engagement and patient partnership. And along the way, I'll share with you some of the evidence that we have already and share with you how the evolution of patient engagement is occurring and how it has been occurring over the past decade. I love funnies because it lightens up the conversation, and this is one of my favorites. And while it's a silly one and a funny one, it also sort of shows to us and demonstrates to us the evolution of patient and family engagement. Maybe we should be asking the patients what they think when it comes to health quality. So some of the principles of effective patient engagement, patient partnership, and I want to start here because they are incredibly important when it comes to how you can effectively support patient partners to work with you on your innovation challenges, on the policy work that you're doing, or perhaps the program work you're doing. And I am talking beyond the innovation challenges because as I'm watching the chat box, I'm seeing some of my friends join us, like Donna Rubenstein. I'm seeing Anila in her new role in Alberta, which is thrilling. And so very excited to see those patient partners who are here, as well as program people and persons who are involved in the innovation challenges. So back to the principles. Onboarding, extremely important. It's like a fish out of water when you bring a patient partnership into your work and you don't offer them effective onboarding or orientation to, number one, your organization and how your organization is structured, the culture of your organization, what's important and valuable to your organization, what your strategic principles are, and also a little bit about your engagement culture. How far along are you on that engagement capable spectrum, which we're going to talk about shortly? Onboarding, clearly important. The other principle of patient engagement is early and often. Too many times I have seen organizations say, well, listen, let's get ourselves organized, let's have a few meetings, and then when we're ready, we'll bring in the patient partner. And so with all due respect to some of you who may have taken on that type of strategic approach to the work that you're doing, it really is not an effective way to do patient engagement. Bringing your patient partners in early helps you to define together What is the problem that we're working on? What are the solutions that we're driving towards? How do we want to structure this work that we're doing and structure it together? Your patients are more about their lived experience. They are about bringing in a perspective that you do not have in your organization. Education is another key principle. Again, bringing a patient into your organization without offering them some background, transparency, and good communication about the material that you're working on, some background documentation that is appropriate, puts them in a less than powerful position, in a more vulnerable position in the conversations that you're going to have. So early onboarding and education go hand in hand. Diversity, equity, and accessibility. Let me tackle those three together. You need a diverse patient population. Again, too often I have seen retired folks around the table. Very important to have that population set. What is challenging there is that you're getting an opinion that is similar and has great similarity. And the reason that why we get the 40 plus or the 50 plus crowd, or the persons who perhaps have the time to do this, is that they have the finances to support them to get to and from meetings. They have the availability in terms of time. Perhaps they feel less vulnerable and more comfortable sitting in a boardroom type setting, or in a healthcare setting or organizational institutional setting. Just a few examples. Building diversity takes work when you're recruiting and engaging patients. It takes setting up some financial incentives perhaps, or some supports to bring those patient partners to the table. It also requires some targeted recruitment and reaching out to patient partners who aren't coming from traditional areas that we are more comfortable with. Equity is incredibly important as well. And so what I mean by equity is being able to support your patient partners in whatever they need to actively participate in the work that you're doing. That might mean getting into honorariums, or getting into offering access with travel or accommodations. It might mean having a conversation around the table about shared power and shared time in conversation. It also means ensuring that you are following a principle of never one, always two, preferably three or more. And let me tell you, I just came from a meeting this morning, an excellent meeting with provider organizations, talking about a pan-Canadian approach to virtual care, and I'm the only patient partner at the table in a group of 20. Wow. So I've succumbed to it as well. There is that equity issue at the tables I sit at. But as patient partners, we need to speak up. And as with those of you that are working with patient partners, this is a key principle. Never one, always two, preferably three or more. Accessibility, incredibly important. Patients, families, caregivers can't always meet Monday to Friday, 9 to 5. How are you structuring your meetings? What's the time of day? Where are you holding your meetings? Sometimes it's triggering for a patient partner to come to a hospital setting to have a meeting. Is that part of your consideration of how you're structuring your engagement-capable culture? Are you ensuring that your meetings are not running for 8, 10 hours straight? Is that something that your patient partners can participate in when they're dealing with perhaps chronic or complex or acute healthcare issues? What does your accessibility look like when it comes to partnership with patients? Defined role and shared purpose, incredibly important. Level setting at the very beginning, again, going back to early and often, is incredibly important to the work that you're going to be doing with your patient partners. What is their role in the work that you're going to be taking on, and the activity that you're going to be taking on? And do you have a shared definition of the purpose? Or are you simply wanting your patient partners at the table to offer feedback and advice? That needs to be made clear, and it'll be up to your patient, family, or caregiver partner to decide beyond there if they will continue on in that type of engagement capable culture, or if they would be seeking more and would prefer to step away. Define that role, define that shared purpose is something you have to establish early in your innovation challenge, or your program, or your quality improvement exercise, whatever it might be. Power dynamics. Power dynamics are something that are sort of quiet and silent in the work that you do with your patient partners, but they're also incredibly important. When a patient partner is coming to a table in a room full of physicians, in a room full of perhaps bureaucrats, government folks, that can be a very challenging space to speak up and to share lived experience, or to disagree with points that are being raised in the room. How are those power dynamics being managed? What is the level set that's occurring within your organization to ensure that your patient partners have an equal voice at the table? And finally, the main principle, lived experience is essential knowledge and expertise at all of your tables. There really is no space where patient partnership cannot be helpful to you. Mm-hmm. And we've learned that through our executive leadership program here at CFHI, where we have incredibly interesting projects that are conceived by our senior executive leaders, and they often wonder, how do I fit a patient into this space? And they come to the realization that there is in potential anywhere across the healthcare system to have lived experience as a shared purpose when it comes to defining the project that they're working on. I love this diagram by my friend Marie-Pascale Pommy from the Centre for Excellence for Patient and Public Partnership at the University of Montreal. Marie-Pascale is a PhD, and she works often in this space of patient engagement and patient partnership. And what she's defining for you here is an incredible continuum that demonstrates the evolution of patient engagement towards partnership in care. I would say that we have moved very much from that left-hand side of the spectrum of paternalism. We rarely see that in the healthcare system now, although it can still exist, where everything is done about the patient without any inclusion of their voice or of their opinion. It still exists in some of our spaces when it comes to policy development, program development, even the innovation work and quality improvement work that we're taking on, but we are seeing a shift. Patient-centered care is a term that we are seeing more often used in the environment now. And it's great, again, to see that evolution towards how do we include the patient in the work that we're doing. It's very much focused on feedback and advice and that cycle of patient engagement. My concern with patient-centered care is it's more of doing to the patient, that patient at the center, than it is of doing for. And so when it comes to interpersonal care, it really should be about partnership. When it comes to program development, policy development, quality improvement, patient safety, innovation, that long list, it really is about partnership. Potentially when it comes to the system and how we design the system, perhaps there is an opportunity there for a patient-centered focus, meaning let's get it away from the system and what works for the system, and let's get it more focused on the patient. But again, it's a term that I feel we're evolving away from. What we're getting into, the space we're getting into from a pan-Canadian perspective, those that are leading in the space of engagement, capable cultures, is patient partnership. Partnership in care, partnership in policy development across the healthcare system, partnership in programs. And that's about doing with the patient rather than for the patient. So I'm going to offer you a few definitions over the next little while, and I don't know if my friend Mark Weir is on the line. He said he would be, but this is a definition that Mark and I came up with when I was in my role as the chair of the Minister's Patient and Family Advisory Council for Ontario. And so I want to offer him that credit as well, where we got to talking about what does patient experience really mean. And it really is about the assessment and how the patient is living that experience of care from the time that they first connect with the healthcare system. It's influenced by the processes that they undergo, the physical setting of their care. What does the waiting room look like? Is it dark and dreary, or is it nice and light? It is impacted by the relationships that they develop with their care providers, but not just with their care providers, by anyone who is working within that healthcare organization, from administration to the cleaners to security to the volunteers that are sitting at the front desk. It is also shaped by expectations. When do we expect to be seen? How long do we expect to wait? What is our expectation around care? That is the definition of patient experience. Patient engagement is different. Engagement is about the involvement of patients, families, caregivers, clients, residents, the public, and I'm deliberately listing a longer list here because it isn't exclusive to any one type of person. It's about the engagement or involvement of people in decision making and active participation in a range of activities across the healthcare system. And I've given you an example there, but there are many more, including policy, quality improvement, patient safety, innovation. It starts from the premise that patient experience and lived experience is an area of expertise that's quite frankly unmined. We're starting to scratch the surface of it, and we're starting to understand and appreciate the impact it can have on the healthcare system, but we're not quite there yet of valuing it as expertise. People engagement involves collaboration and involves partnership, and that's going to move me to our next slide. So again, I apologize. I forgot to cite the reference on our previous slide, but you can see it there at the bottom. This one, again, goes back to some credit to my colleague, former colleague, Mark Weir. Patient partnership. What does patient partnership mean? How do we define it? It's about active and purposeful collaboration. Active and purposeful, and that purpose being defined together. It's looking at shared values, experiences, and knowledge, and incorporating that not just into care discussions, the one-to-one care between the patient and their provider, but also across the healthcare system. Again, it applies those values of shared power, shared purpose, and responsibilities for defining and shaping many aspects of the healthcare system. So what does patient partnership mean for innovation and for this innovation challenge? Patients and families challenge us to see the blind spots. They are the ones who are touching every single point of the healthcare system across their healthcare journey, and they are seeing the challenges and barriers firsthand. They push for the innovation. Where things are not working, patients will find a path, and those pathways that they are finding are innovations. Patients and families have intimate knowledge about the barriers that exist across the healthcare system and the limitations that affect their experience as patients, that affect their safety, and affect them achieving optimal health. One of the things that you can do as healthcare organization leaders or people who are involved in government or involved in policy is figure out, how do I create a safe space and an appropriate space for patients to share what those barriers are? Right now, we tend to look for either compliments or complaints through our patient relation processes. Those are not always safe spaces for patients, and so a challenge for you as you think about innovation and quality improvement across the healthcare system is creating those safe spaces for patients to speak up. Patient and family partners focus on care improvements. They don't want to wait for their care, and so they're going to find ways to manage themselves through the healthcare system. Now, I'm talking about very activated patients, and we think of a patient activation measurement scale, the PAM scale. These are very activated patients. They bring facilitators and solutions. They are very important when it comes to patient engagement, but equally important are the patients who might not be as activated, who might not be as knowledgeable. They still have lived experience that's incredibly important because they bring a different perspective of how the healthcare system functions for them and how they can be integrated into the system. That comes back to the comment I made earlier about diversity in who we are partnering with as patient partners. Everyone can't be a level 4 activated patient when it comes to a patient partner. We need to think about different layers and layering what that diversity looks like in our patient partnership.
Julie, do you want to take a question actually on diversity, because it's come up in the chat box. So first, Anila raises it from the Canadian Partnership Against Cancer, and she says it's hard to get diverse voices in an advisor role, so what other mechanisms do we need to consider? But then we've just had another person make a comment from Fraser Health who says the diversity and patient engagement conversation, I think, should focus more on intersectional positionalities, race, gender, education, rather than on age. And I know you would use that as an example. Yeah. So just along those same lines, people are clearly thinking about diversity because, you know, this is Canada. So I guess to Anila's point, just practically, it's difficult to get diverse voices. How do you do it?
Yes, and Lupin, thanks so much for that. Yeah, age is the easy one, and I picked the low-hanging fruit, but you're very right. Race, gender, education, rural and remote in terms of geography, access. There's lots of ways that we can slice and dice diversity, and we have templates for that exist. I'd be very happy to share post-call if that's something that would be helpful to the group that are on the line today. And Anila, thanks so much for your question, and I think it's a comment as well, is how do you get diverse voices at the table in an advisor role? And this comes back to my colleague Angela Moran, who's now at the Kingston Health Systems organization. Angela will talk about a mosaic approach to patient partnership and bringing in that diversity. We can't expect all patient partners to want to sit in on a meeting, be part of an advisory group, be part of a patient and family advisory council or a steering committee, what have you. And so selecting from a range of different engagement approaches. It might be as simple as a survey, but a survey that's constructed for and with patients. It might be as simple as a focus group phone call. It might be something as simple as bedside conversations. That's something that can occur in our healthcare system and we don't use very often. It might be a short-term focus group. It might be going out to community and working with some of our partners in communities such as community healthcare centers or community organizations, community groups, and many of them exist that we don't often leverage. We don't often think about outside of our own healthcare organization to find those communities that are organized around culture, that are organized around age, that are organized around healthcare system interaction, for example, cancer groups or diabetes groups or rare disease groups. So there's many different ways to do it. I think what we have to think through before we start to launch on an initiative is how are we going to engage? How are we going to ensure to the best that we can diversity? And I want to make a comment about diversity. It will never be perfect. Unless you're talking to every single Canadian in this country or in your province or in your hospital, diversity will never be perfect. But choosing a very, very broad, and I apologize for the word, but lens is incredibly important, and in choosing a mosaic of approaches, incredibly important. So Anila, I hope that's helpful, and Jennifer, thank you for the question.
You bet, and I'll just say that, this is where I love when we get in chat, because people have added contributions to the thinking of diversity. So I'll just state this, and then we'll have Julie move on. But
Maggie said just what I said.
Maggie, hi Maggie,
Yeah.
so mentions diversity also refers to the fact that patient partners are heterogeneous, and each person's voice has a unique perspective that may seem nuanced but is valued. And throughout the course of the chat, people have also expanded the definition, Julie, as you were talking. Age is a factor, race, gender, education, language, culture, attitudinal differences, socioeconomic status. And I'll just reference back that 6 levers framework, which was created based on evidence around what does a high-performing health system look like. It's the reason why you have those 2 levers situated side by side around population health. Who is the population that you serve and what are their characteristics, and the patient and community involvement. There's always going to be some imbalances and trying to strike a balance between those two, but it's important to know who's the population that you serve. And back over to Julie, and keep those questions coming, and don't forget, if you signed in a little bit later, please introduce yourself. We love when you do that. We'd like to know where you're coming from.
And I love seeing the comments coming through the chat box. I definitely am not here as a keynote lecturer or anyone with a PhD in patient engagement. Even if you do have a PhD in patient engagement, to Maggie's point, there are many different perspectives and many different ways to slice and dice this. So we have got a lot of actually expertise in our chat box and on the line. And so it's great to have this dialogue back and forth. This is a space that is ever evolving and ever moving. I think the foundational part of this space, and this again, my personal perspective and in my opinion, is that we really need to think about it as partnership, engagement and partnership, and that shared power, shared decision making, shared purpose are very important. I often will hear when it comes to shared decision making from healthcare organizational leads, that's not possible because I have a certain amount of money or a certain amount of resources and we can't have shared decision making. But again, it's how you define shared decision making. It's how you are conceptualizing that and how you're structuring that together. I might not be holding the financial purse strings, but I have an expectation about what we can define as shared decision making between the two of us. And Sabrina's just reiterating Maggie. Great point, Maggie. Patient voices are unique and have unique lived experiences. Yeah, absolutely. We're going to go into a polling question now because I want to get you guys talking a bit more, as you already are, about engagement-capable environments. And so, in order for patient engagement and partnership to be effective, organizations really must support a culture of engagement-capable environment. And so I've offered for you below a list of 5 organizational strategies that support a culture of patient engagement. And we're interested and people are already starting to answer, that's great. We're interested to hear from you about choosing the 3 areas that your organization is leading in, and if you can offer a brief example or description. Again, let's take the opportunity to learn from one another, from all the expertise that we have on the line. I'll give you a few moments to do that. So we're giving a moment for these answers and responses to come in because they shift and change. I always find it really interesting when we do these polling questions, and we've done it twice before, that number 1 tends to kind of, pull pretty high. Now what's coming out here is we've got 71%. My organization has patient and family advisors as part of organizational committees and working groups. So it's really interesting to see that there's organizational spread of patient and family advisors, and that they're integrated across an organization, not just sitting in a patient and family advisory council. 7 organizations are reporting that. The space, I find it really interesting as well as the last one. This is an area that CFHI is very focused on, and are certainly through our Bridge to Home program and our Better Together programs, emphasizing policies and practices around patients being part of a collaborative care team and participating in their care. And when I say patients, I'm including families and caregivers in that. So it's interesting to see that we're at 12% there. And I'd be interested in whomever responded to offer us some examples of what they're doing in that space. Nova Scotia Health Authority has a Patient, Family, and Public Advisory Council that is available to all teams and programs. So we're seeing some provincial movement here. Of course, Ontario has the Minister's Patient and Family Advisory Council. We know we've got BC Patient Voice. We've got Imagine Citizens in Alberta, and it's interesting to see some of the health authorities and provincial health organizations bring in patient and family advisory councils to offer that anchor. Not the be-all and end-all, because we need a multitude of perspectives, but it's nice to see an anchor of advisory councils, I believe, provincially.
All right. Okay, we're gonna close the poll. Thanks everybody for participating, and if you do have additional comments, we'd ask you to share those in chat, and don't hesitate. If you have experiences, we know there's a lot of rich expertise on the chat box, and on the line. Share that as well as questions.
Just going to leave this here for a minute.
Right.
Our ladies in the booth that helped facilitate our webinar are saying, best slide ever. Chat box, I'm waiting for it to fill up.
This never happens, Julie.
Yeah, it happens all the time. It happens in, yeah. Thanks, Maggie. She loves the dog-cat slide. I think this one it's ironic and it's funny and it's kind of a tease. It happens every single day in the healthcare system, right? It happens in actual patient care, where there might be a group of providers making decisions for a patient, about a patient, without the patient in the room. I think it potentially could have happened today at the Pan-Canadian Virtual Care Task Force with a whole bunch of physicians in the room, well-intentioned, well-meaning, highly knowledgeable, but talking about care of a patient virtually without patients, families, and caregivers in the room. So we really need to think about this. This needs to be our true north, is who is at the table making the decisions about how our healthcare system functions. So I love this slide. Again, it's another CFHI slide. It's talking about the relationships that need to build. This isn't a thing that just sort of happens overnight for an organization, and it doesn't happen off the corner of someone's desk. Tag, you're it, you're in charge of patient engagement. This requires relationship building. It requires leadership. Key is leadership. It requires leadership all throughout an organization, from the very top and all the way through. So it requires enlisting and preparing patients, and that's not to say that the patients have to drink the purple Kool-Aid of the organization, but it does mean that they need to have an understanding and appreciation of what their role will be as partners with that organization, and they need to be comfortable with that. It includes a lot of communication between patients and staff. Staff need to be really well prepared for what patient engagement and partnership mean in order for it to be meaningful and helpful. It involves having supportive teams that understand engagement, that understand the principles of engagement and partnership, and how to support that across an organization and also with the patient partners. So those persons who work in patient engagement and have that expertise, they are key to this space, and including them to help us remove the barriers is incredibly important. It requires a strategic focus. How is patient engagement and partnership defined in your organization? Is it part of your values? Is it part of your strategic lens that you're working on? Is it part of how you are defining strategy within the different areas of your organization? And so asserting that patient experience and patient-centeredness for the system are key values and goals. And I'm looking on our chat box right now. Kristen has shared some sort of resource, and Sabrina's thanking her. So, Kristen, we're going to capture that and ensure that it comes out following the webinar. So this is from the NSHA, also uses an online platform that allows members of the public to be involved in online consultations. Again, not being biased to Ontario, but that's where I live. Ontario, through the Health Quality Ontario, as well as the Ministry of Health, have also engaged with virtual networks of patient partners. So the Ministry has over 800, Health Quality Ontario at last count had close to 600, and they regularly go into those pools of patient partners, identifying where they're doing policy or program initiatives and where they need patient voice. So thank you so much for sharing that, Kristen. Very helpful. I'm not going to belabor the evidence, but I did want to include a couple of slides here to show you and to demonstrate that engagement and partnership are evidence-driven. So if you're getting pushback from your leadership, or if you're a healthcare leader and you're sort of unsure about this space and really how is it landing, the evidence in terms of academia is building. We know that patient engagement and an engagement-capable organization results in a better culture, joy in practice, inclusiveness, increased compassion, improved experiences. It results in better care, care plans that match patient goals, transitions in care that are supportive of family, caregivers, and patients, decreased readmissions. We know that it results in better health, improved patient-defined outcomes, and reduced illness burden, for example. And we know that patient engagement and engagement-capable environments result in lower costs. And again, this is one example of the evidence that is building in this space. We also know that we still have a ways to go. We talk quite a bit right now in the patient engagement and partnership space about co-design. And I'm going to pick at this one a little bit, because what do we mean by co-design? What is happening in the co-design space? Who gets to decide what co-design is and is not? And so we still don't have a strong body of evidence around co-design, quality of it, the methodology that we should be employing. We know it's an emerging opportunity for effective engagement and partnership, but we need more work in this space. And I'd be really excited and interested, again, in the chat box from some of our patient partners or people who are working in this space to offer some examples of areas where they are involved in co-design and what's effective and what is not. I'm sure many of you on the line recognize the Carmen framework. It's been around for several years now, but it always is a great framework to reflect back on. I think what is perhaps missing from Carmen as we start to move along in these conversations and we see this evolution in patient engagement is that the arrows are not unidirectional. They go back and forth depending on what that patient is comfortable doing in terms of engagement and partnership, and also where the organization is comfortable. And also, we're missing some arrows that connect direct care organizational design and governance, and policy making, because they intersect as well. But Carmen is a good place, a good launching pad as a starting point. Care is not discrete, and what is happening between these spaces is also very important. The next framework that I'll refer you to has been developed by IAP2. I love IAP2 because it shows, again, this evolution that we're experiencing in patient experience, patient engagement, and patient partnership. And we're moving into a space of leadership, to a place where final decision-making is in the hands of the patient, family, caregiver, and public, and where the organization will implement what the public decides. Isn't that interesting and challenging to us in regards to shared power and governance? Again, I won't belabor this slide, but I think it helps open up a lot of nice dialogue around what is the patient role in this space of innovation and improvement across our healthcare system. So we're going to open it up for discussion again, although the discussion is ongoing. There's some really great comments here in the chat box. I can summarize. Jen's going to summarize for us.
Yeah, so Anila made the point that co-design is quite impactful, and it's important to have an engagement-capable environment for that to be successful and possible, and also targeting the right projects and initiatives for co-design where you can truly have co-design. Maggie makes a point about the engagement-capable environments needing to be broad in scope, so ensuring individual patients are in an environment that supports engagement in their care experience, but also thinking about patient partnership with the system at large. Policy sort of meets practice, micro and macro. And she further talks about this sweeping change, of course, happening across Ontario, the Ontario health teams offering a unique opportunity for patient partnership at this time, and the window to ensure patient voices are key in co-design across Ontario health teams. So those are the main comments that came through. Otherwise, people are asking if these slides, which are superiorly helpful, but every slide has a resource, Julie, they wanted to know if they're available post-webinar, and absolutely. The webinar recording and the slides and materials will be available to folks.
So as Jennifer said, slides and materials available, and also I'm available. So if you want to email me and you have questions or you want to have a conversation, more than happy to do that, and that's very much a part of my role here at CFHI. I wanted to open up just briefly to, again, a discussion through the chat box about some of the challenges and barriers that you might be facing in terms of partnering with patients and families and caregivers, and how do these challenges and barriers become opportunities. There's a great amount of experience right now on this webinar, on this call, and so we're going to take a pause here and let you type in some of the challenges and barriers you've experienced and how you've flipped those into being opportunities.
Okay, so we do have our first Mark, of course, who we heard earlier, contributed to those fabulous definitions Julie shared. One of the biggest barriers that he hears from staff is time, because patient engagement is so relationship-based. Do you have any advice for people who see the benefit of investing the time in relationship building, helping people see the benefit of putting in that time?
Thanks for that question, Mark, and I'm just wondering why you didn't answer it yourself for the group. So thanks for putting me in the hot seat, and I'd be interested for others to weigh in on this question as well. So here's some of my thoughts on it. I think first and foremost, when it comes to provider and patient, and again, coming hot off a meeting this morning with a number of provider organizations, there's a clear understanding and appreciation that we need to build in patient engagement and patient partnership into our medical school educational system training. That has to happen at a pan-Canadian level. It's happening in pockets right now across the country and at a very sort of basic level around patient experience, but we need to move the marker on that and to identify how that relationship building is incredibly important. I think the other space is that we need to be on an opposite spectrum in terms of organizational leadership. We are rebuilding our extra program here at CFHI, which means to say that a 15-year program now is going through a reboot of building in throughout our modules patient engagement, patient partnership, and patient leadership in the space of what does it look like for an engagement-capable organization, and what does it mean from a leadership lens? What are the values, the principles, the resources that are required? And one of the resources, as Mark is reflecting on, is building relationship and taking the time and demonstrating through evidence that again is building that this is an important piece of an organization that is effective in a healthcare space.
A couple other comments I'll just say back to back here. Co-design on research from Donna Rubenstein. She says, as a patient partner, there's tremendous difference when I'm brought in early versus post-grant approval. Her contribution is limited at that point when the team's already developed a plan and has a lot invested in it. Another example here from Maggie, that one of the challenges that she faces is lack of visibility of patient experience in organizations, for example, in hospitals. The patient experience is often hidden away in the back halls, it's not visible to patients, and she'd like to see a culture change where the patient experience is forward-facing in organizations. Mm-hmm. Calgary Foothills, Jackie. Recruitment has been a challenge, so she appreciated some of your suggestions around tapping into community partners, changing the meeting times, thinking about the things that create barriers for people to be able to participate.
And I really love that comment, Jackie. I was talking to, I had the privilege of meeting Somerset West Community Healthcare Center here in Ottawa. And we've got 6 major community healthcare centers in our downtown core. Somerset West is the leading one. And I was invited just to come and learn about their community healthcare center. And sitting around the table were persons who had previous habituation to opioids, single moms, new Canadians, a woman who was previously a professional who's now on leave from her job to care for her husband who had a traumatic spinal cord injury, and she's trying to navigate the system. Just like diverse range of people and perspectives. And what was really interesting to me from hearing from many of them is what makes them comfortable in a meeting space. And one of the comments was food. If you feed us, we will come. And then we started talking about culturally appropriate food. And some of the culture of our patients, food is very much a unifying force and a unifying space. So what else unifies us? What else gives us comfort, supports us? Breaking outside of our traditional boxes of a Monday, Friday, 9 to 5 bureaucracies that we might work within as individuals, and thinking about what builds relationship. What builds empathy, what builds compassion, what connects us as humans and individuals, and thinking about it from that space when it comes to engagement and partnership. So thank you again for that comment. So we'll close off that discussion of barriers and challenges, but if you have more that are sort of percolating in your brain, please feel free to type them into the chat box and the team will be capturing them. I think we've already preempted this slide, but we were talking a bit earlier about fit for purpose and considering a mosaic of engagement methods. And there are many of them. And so really being creative, thinking about the population, thinking about the project that you are going to be bringing on, and who do you need to be hearing from at the table, and then rethinking, okay, I'm thinking about who I need to hear from, who else do I need to hear from? We have a philosophy here at CFHI, which I love, which is called Even Better If.
Oh, even better if.
Even better if.
Yeah, see, it's so ingrained. It's just...
So even when we think about the work that we're doing, we'll close off some of the work that we're doing. We'll think, that was great, and even better if. Mm-hmm. And so consider your range of approaches and what else would improve on this. If you're not subscribing regularly to Dilbert, I'm going to advocate for you to do so. We actually have a Dilbert subscription at CFHI in our top-hand corner. This is an oldie but a gooder, and I'm going to read it because I just think it's so silly. Before I make my decision, I'd like to ask for your opinions. It's supposed to make you feel, air quotes, engaged. And then Dilbert turns to his boss and says, and you actually plan to listen to us? I'm hoping it will look that way on the outside. Oh. So let's talk for a minute about tokenism, the fully baked cake. Have you ever seen a cooking show where the chef is stirring away and they're chatting with you and talking about the ingredients that they're using, and they mix up their cake and they put the batter in the pan and they shove it into the oven, and meanwhile they pull out the fully baked cake. And you're thinking, man, I thought I was engaged in this process. I thought I was a partner in this. I thought we were baking the cake together and picking out the ingredients, and maybe I didn't even want a cake. Maybe I wanted a pie or something more savory. The fully baked cake is your true north of tokenism. Where are you at in how you are including patients? Early, often, shared, purposeful, values that you are setting out and basing together. And this is hard to do. This is not easy work. And again, it's not off the corner of the desk. But bringing your patients into an experience, your families, your caregivers, your clients, your residents, where it is a tokenistic, will only breed a negative environment. I will guarantee you, as soon as tokenism, and patients can sniff out tokenism in a heartbeat, in a snap. Even if they're not really sure what it is and that it's a tokenistic thing, they'll feel it. And that is a space for an organization, for you as organizations, to really take a step back and think about what does our engagement approach look like, to really plan this out in a thoughtful way with your patient partners before you embark on the journey. I love this comment by Jem Lee Harder. It's important that the organization leadership are committed to support a healthy budget to eliminate barriers. Very important. Transportation costs, child care, or care of your loved one. What if you're a caregiver that wants to engage, but you are actually the person caring for the patient at home? Interpretation services. We don't all speak the same language. We come from many different cultures. So thank you so much for that comment. I'm going to close off with two slides that I really adore that before I came to CFHI, I had actually, filed away in my own inbox as a patient engagement person and a person working in the space of engagement. The first is the lessons learned from patient and family advisors. And again, they reiterate many things that we've been talking about on this webinar today, clarifying the role, educating others on my role and the value that I bring. And so that was Mark's comment earlier about how do you build in those relationships and educate your teams and your organization about the value of patient engagement and partnership. Equipping patients with the information they need to be successful, involving them from the beginning, including the patient advisors in the goals and including them in more is better. And so I won't read through all of those, but they're great lessons learned, and it's wonderful to see how this has been articulated by CFHI. It's an example of an organization that has been able to adopt an engagement-capable environment. And I wouldn't say that it has been maybe easy, and it's a continuous learning. Jen, I don't know if you want to comment on that.
Yeah, absolutely it has. I mean, I think about one of the first collaboratives that we had hosted around patient and family engagement. That was both the first experience for some of those teams to bring patients and families to a meeting of that kind to talk about quality improvement. It was also a first for us. That was back before 2010. Now when I think about we're a collaborative-rich organization, we have a number of quality improvement collaboratives, and many of those would be impossible to deliver without having patient and family advisors at the table. Often because, these are certainly cases where we're working with older adults with complex chronic conditions. They need their family caregivers. The caregivers are playing an immense role, an immeasurable role, peer support. But just having those insights that, we don't get when we don't have patient and family advisors at the table. So it's certainly been a lesson learned for us that I think we're learning alongside our teams.
And so the next insights, lessons learned, are from the healthcare providers and leaders. And again, I won't read through these. You've got them in front of you, but they're great takeaways, and we have these as resources within CFHI. You're welcome to print them off and share them within your organizations. Again, it goes to an opportunity for you to share within your organization the purpose of this, the value of it, and how it can actually lead on being an engagement-capable environment. CFHI has some incredible resources. We have what we call a patient engagement resource hub, where you can find tools to improve patient engagement, your patient engagement practices. These come from multiple organizations across the country and internationally. It's a searchable database, really effective tool, and I thank many of you who are on the line with your organizations that probably contribute to this hub. And I've offered some references in this slide presentation as well that are going to come your way in regards to quality improvement primers, references and resources in terms of some of the tools and toolkits that are out there and existing to help you get started in this space or help you to improve your practice in this space. I'm going to turn it over back to my colleagues, to Jennifer and to Lindsay, taking up a ton of time to talk about the Priority Health Innovation Challenge at CFHI.
Time well spent. So, this is what we do. If you guys wanted us to stay there, we stayed there. So Lindsay's going to take a couple of minutes just to give you a brief overview of the Priority Health Innovation Challenge, but you can certainly find more out about this online. And all of our Priority Health Innovation webinars are open, so we invite you to participate and join in those.
Yeah, absolutely, and thank you everyone for a really rich discussion, and Julie for leading that and sharing so wonderfully of her expertise and skill. So whether you're part of the Priority Health Innovation Challenge, you're considering joining, maybe you haven't heard of the Priority Health Innovation Challenge, you're just working in healthcare, you're here today, we're happy to have you. And we did want to just share a bit about the Priority Health Innovation Challenge while we're here together. So jumping right into Priority Health, the challenge is our way of engaging teams doing work to improve access to mental health and addiction services and home and community care. The challenge allows teams to register an existing innovative project or program, or you can also start a new one. What we ask of you is that you share your progress. That includes your data on patient outcomes and reach. So teams can enter from now until August of 2020, but teams who are joining us, the sooner the better. So we have some teams on the line who were just awarded $10,000 per team for some work that they did around stakeholder engagement, including patient and family engagement. So it's a great way to have some resources available for you to do the work that you need to do. We talked about resources and how those are limited. This is a great opportunity to connect those. In January, we have awards coming up, and the total award allocation is $150,000 total. So great opportunities coming up, and that's what we just really wanted to share with you today. So participating in the challenge allows you to interact with like-minded teams across Canada. It allows you a chance to share and increase your impact that you're making on improving client care. Again, there's lots to be learned, as we've seen from the expertise in this room. There's lots of knowledge and expertise out there, so we also try and bring you together so that you're able to access that. Teams join webinars just like today. They participate in award challenges, and as I said, there are financial awards throughout the challenge, up to $400,000 available, so certainly substantial. We want you to keep doing the great work that you're doing, so if you're successful in receiving an award, as I said, you can use that money as you choose. I mentioned a few moments ago about data, so I do just want to ensure I highlight that. These are the 12 indicators that we're focusing on. To register your program or project, you will need to share your data and your progress towards improvement on one of these indicators. A very simple step in sharing that with us on a monthly basis. And if you're in the early stages of your work and you don't yet have data, that's not a problem. You can register anytime, and once you have data, simply agree to share that with us. We're looking for teams doing innovative work with early results that ultimately will lead to future spread and scale, improving access to mental health and addiction services and home and community care. So I know we've provided a really brief overview today, but please know the Challenges team is here to support you with any questions you may have. We're hoping it gives you a bit of information to see that you may be interested, you may simply want more information to understand if it's a fit for you. Please reach out to our team. I see Sabrina has also included our emails in the chat box. We're here. The Challenges email will come to any one of us, and we're happy to follow up and see how we can support the work that you're doing. So what I will do is probably turn it back to Jen.
All right. Thanks, gang. So we hope that gives you a high-level information to whet your appetite about what is the Priority Health Innovation Challenge. These are areas where, how could we possibly improve access to home and community care, mental health and addiction services without integrally involving patients and families, right? Which are, in effect, they're doing this work where the health system is, having gaps. So it's an area where when you look at those indicators, some of those we'd consider -1 indicators. Unfortunately, we look at keeping people out of hospital as an indicator of improving home and community care. But there are also indicators in that list that are quite progressive. Caregivers. It's framed as caregiver distress, but we also want to think about it, and many of the teams involved are thinking about it as how do we get to caregivers before that distress sets in, right? How do we have early detection in a health system that's acclimatized to dealing with acuity? How do we actually promote health? I think the only way to get at that is by involving communities, patients, families, right? Home is where the health happens, and that's what this challenge is about. Feel free to join our upcoming Priority Health Innovation Challenge webinars. They're all online. Julie gave you an offer today. If you wanted to talk more about patient experience and partnership and engagement, the rich number of resources, she's a resource to you, which is incredible. We're enjoying Julie's participation here at CFHI. She's enriching our work and lives, and she can do the same for you. And then similarly for the Priority Health Innovation Challenge, you've got Lindsay, based in Kingston, but virtually everywhere, and Sabrina, actually based in St. John's, Newfoundland, Labrador, also virtually everywhere. I'm Jen. I want to thank everybody for joining today. We've appreciated your input. You're all experts, and we've seen that come through. Julie, Lindsay here at CFHI. We've also got our producers behind the scene. Emily's been managing the chat. Thank you guys for doing that. All of you for joining us today. We do want you to take a couple minutes to fill out this quick poll. To Julie's point around even better if, we do a lot of these webinars, but we like to learn from each experience. So thank you, and tell us if what we did was effective for you. That closes today's webinar.
And this concludes today's webinar. We thank you for your participation. You may now disconnect your lines and have a wonderful day, everyone. Take care.